everyone. My name is Abeeha Naqvi, and I'm a second-year cardiology fellow at Creighton University in Phoenix, Arizona. And I'm here excited to welcome Dr. Brian Lindman, who is a medical director of the Heart and Valve Surgical Center in Vanderbilt University.
Yes, thank you. It's great to be with you.
And we're here to discuss the cardiac biomarkers in patients with severe asymptomatic aortic stenosis, part of the primary biomarker analysis from the early TAVR trial. To date, there have been no randomized trials looking at percutaneous interventions for asymptomatic severe aortic stenosis. So did you want to review the trial results?
Yeah. So the early TAVR trial, just to frame for the listeners, was reported out last year, and that was testing whether or not patients with asymptomatic severe high gradient aortic stenosis would benefit from early TAVR compared to clinical surveillance with deferred valve replacement when symptoms occur. There have been 2 prior trials testing a strategy of intervening with surgery, but this was the first and the largest to look at transcatheter aortic valve replacement as the intervention.
And what were the primary outcomes for the early TAVR trial?
Yeah, so the primary endpoint of that trial, which was positive, was death, stroke, or unplanned cardiovascular hospitalization. And there was a hazard ratio of about 0.50, indicating benefit from early intervention compared to clinical surveillance. And there was a benefit of an early approach for several other secondary endpoints that they looked at as well.
And looking at the cohort that were in the surveillance section of the trial, many of them, about 87% of them, received a TAVR within 12 months.
Yeah, there was a high degree of conversion in the clinical surveillance arm, and they happened more quickly than we might have anticipated. 24%, I think, at 6 months, and almost 50% at 1 year. And in the trial that were in the data set that was presented in the publication, 87% had by that time already undergone valve replacement. So this was informative also in terms of understanding the timing of conversion and also the mode of presentation when they did convert.
Would you say the mode of presentation, their change of symptoms became worse just symptomatically because they became aware of it, or was it a gradient-based objective finding that just increased and got worse?
I mean, all these patients were rigorously assessed before the trial with a normal treadmill stress test. They had an average KCCQ of 93. These were asymptomatic people. But what was surprising is I think we tend to think that patients are going to just present with these mild symptoms, and in a third to 40% of cases, they presented with acute or severe symptoms, syncope, NYHA 3 or 4 as their presenting symptoms. So these were some of the key findings from the trial that set us up for this biomarker analysis.
So what else motivated you to look at the early biomarker analysis for the early TAVR trial?
Yeah, I think there's been interest in identifying, can we figure out subgroups that may particularly or only benefit from an early approach? And so we had a biobank as a part of this trial, and previous studies have shown that increased biomarkers of troponin or BNP are associated with maladaptive cardiac remodeling, symptom onset, worse outcomes after valve replacement. And so a guideline is based on that, saying that asymptomatic patients with a BNP over 3 times normal may be preferentially considered for earlier intervention. So we wanted to test that hypothesis, and this is the first context in which we have randomized data on that. And so what we found in this sub-study is that as expected, higher NT-proBNP and higher troponin are associated with increased event rates, as we would expect. But when we looked at, is there a differential treatment effect? Indeed, there was not. There was no interaction between biomarker subgroup level and treatment group allocation with respect to outcome. Another way of saying that is that the benefit of an early approach compared to clinical surveillance was consistent for multiple endpoints that we looked at across biomarker subgroups. In fact, contrary to our hypothesis, there was a trend, and in some cases, significant interactions where those with lower or normal biomarkers experienced greater relative benefit of an early intervention strategy compared to clinical surveillance. We also found that NT-proBNP had a very modest but significant association with timing of conversion in those in the clinical surveillance group. This was driven by the lowest tertile of BNP, where they had a slightly longer time to conversion. No relationship for troponin. And then we also examined whether or not biomarkers predicted the mode of presentation, and higher biomarker levels were associated with a higher proportion of patients converting with acute or severe symptoms. But when you look at the 1/3 in the lowest tertile of troponin or NT-pro, still at least a third of those patients were converting with acute or severe symptoms. So having a low biomarker was not reassuring that you could avoid that presentation. So overall, the takeaways are that these biomarkers in patients with severe asymptomatic high gradient AS do not appear to be particularly helpful in tailoring the timing of valve intervention.
And what was the median BMI on these patients?
I think the BMI median was 28 or 9. Yeah.
Because obesity can often decrease
Yes.
some level of these biomarkers.
Yes.
Okay. Another structural kind of based question. Any reason for balloon expandable TAVR use in this trial versus self-expanding valves?
It was sponsored by Edwards.
Okay. All right.
So they used their platform.
And one last question. How do you address concerns about the long-term durability of TAVRs in patients who are asymptomatic, given that early intervention may expose them to earlier structural deterioration of the valves and need for future reinterventions?
Yeah, I'm glad you asked this, because this comes up. It's like, okay, you've put a valve in earlier, but then there's a higher chance of degeneration and need for a second procedure. Conceptually, that makes sense, but what the trial is helpful in showing is that on average, those in the clinical surveillance group who converted to get an AVR, that was 11 months median after randomization. So on average, you're talking about a valve then in the clinical surveillance group going in a year or two later. So if you just consider an example of a 68-year-old and you're saying, do I intervene now or wait a year or two? The probability that 68-year-old, let's just say that the valves last 10 years. The probability that they're going to get to 78 and need a new valve is virtually the same as them being 69 and then 79 and needing another valve. So to me, it makes this durability clock somewhat less material because the clocks are starting at virtually the same time. So I think that's an important consideration, because sometimes that comes up when people think about that.
Excellent. Great. Well, it was great getting your insight on this trial. And, what do you think the future directives are for looking at TAVR in patients with severe asymptomatic aortic stenosis?
Well, I mean, I think in terms of the biomarker piece, to me, this sort of undercuts or undermines the role of that guideline on BNP for timing. But then we will, just because we had these observations in this patient population, it will be interesting to see in the progress trial, which is the follow-up trial in moderate AS. That's a much more heterogeneous group of patients, and it very well may be that biomarkers are helpful in that patient group to tailor or personalize the timing of valve replacement in moderate AS, because I don't think all comers in moderate will benefit. So that's on the horizon.
Perfect. Thank you, Dr. Lindman, for that insight. For more videos like this, check out our channel at youtube.com/FITsOnTheGo. Thank you so much, everyone.